Welcome to Module 3, Behavioral Approaches to Diabetes Care, and I'm going to cover the topic, Changing the Conversation in Diabetes from Discouraged to Engaged. I'm Susan Guzman. I'm a clinical psychologist, and I specialize in diabetes, and I am a co-founder and director of clinical services at the Behavioral Diabetes Institute in San Diego. So just the way you want to start a module with a true or false test. So how would you answer this? True or false? Diabetes is the leading cause of adult blindness, amputations, and kidney failure. False, actually, to a large extent. It's poorly managed diabetes over time that's the leading cause of adult blindness, amputation, and kidney failure. Now that might sound like splitting hairs, but it's actually really important to understand why. When we talk about diabetes, we don't make that distinction, that it's poorly managed diabetes over time that's the leading cause of those things. Another way to put it is this: well-managed diabetes is the leading cause of nothing. Now think about if you were just diagnosed with diabetes, which message would you rather hear? Well-managed diabetes is a leading cause of nothing actually tells you that having well-managed diabetes is worth the work. It shows you why you should bother with all the job of self-care rather than just what happens if you don't. So here's a fact check. This doesn't mean that good care will guarantee that you don't develop complications, but it's kind of like wearing a seatbelt. What it does mean is that with good care, odds are good, you can live a long and healthy life with diabetes. So how many people in the U.S. have well-managed diabetes? So how we define well-managed diabetes is by three important numbers: A1C, blood pressure, and LDL cholesterol. And if you can see from the box on the red, about half the people in the U.S. were meeting A1C targets, and about the same for blood pressure, and almost as well with cholesterol. But we're not looking for individual targets. What we're trying to see is all three targets at ADA standards. As you can see, only about 25% have what we would call well-managed diabetes. Now, when you think about the 29 million people who have diabetes, and you do the math of 25%, it's pretty scary. We have a lot of work to do. So what's the problem here? What's so hard about diabetes? How come only 25% are meeting treatment goals? Well, one of our colleagues said in a standard diabetes education class, some of you may even teach those classes, and she counted the number of behaviors that were actually recommended to be changed. So that's things like learning how to carbohydrate count, check your feet, check your blood glucose, have your A1C checked, start to learn how about saturated fats and meal planning and physical activity. And so she quit counting at 150 separate tasks. And we don't often teach these to people in order of priority. And when you think about diabetes management, think about the slide I just presented to you, that the best outcome is that nothing happens. So when we're talking about well-managed diabetes over time, that nothing happening is a great outcome, but as human behavior goes, it's not very rewarding. So if you were to do your full-time job and at the end of the week you get the outcome of no pay, that's not very rewarding for human behavior. So that while having nothing happening as an outcome is wonderful, for human behavior it's not terribly reinforcing. And then I hear a lot about from people is that what's exhausting to them is the constant need for making decisions. And for those who have type 1 diabetes, they often describe it as mental gymnastics, where you're always having to think about, what did I eat? Did I take my medication? Did I plan ahead for X, Y, and Z? That constant need for decision making can be exhausting for people. And it's a psychological burden. And adding to that, it's 24/7, 365 with no real vacations. And on top of that, it's a moving target. So diabetes tends to get harder to manage over time, and that's not because it's the person's fault. And so just when people have a sense of maybe I got this dialed in, something changes. Either their body changes, their life situation changes, perhaps their medical coverage changes. And it leaves people feeling like diabetes is always a moving target. And they never feel quite good enough. And because it's a chronic illness, like any other chronic illness, there is no finish line. You never get to be done with diabetes. So when we try to use metaphors like it's not a sprint, it's a marathon, Even that isn't really an appropriate metaphor. It would be a marathon that you have to keep running and running and running. And I think one of the more difficult aspects of living with diabetes is that all of these things that I just talked about, most others, and even most healthcare professionals, don't really appreciate how much work is involved in that. So when we talk about motivation in diabetes, we like to say there's no such thing as somebody who's unmotivated to live a long and healthy life. That diabetes is that full-time job that nobody wanted, they didn't sign up for, and you can't quit. So what's the problem in diabetes? So how to think about it is that when the person's obstacles that they have in their life outweigh the understood benefits, they get stuck. And there are a lot of obstacles. So I know this slide is really too busy, but it's really to give you an idea, because this isn't an exhaustive list of the obstacles, but just to give you a sense of what are the good reasons people might be struggling.